Good evening, everyone. What makes us most anxious? Is it the severity of the problem? Is it the complexity? I don't think so. If it is something that is unexpected that happens in the theater, that is what really works us up. So, we are going to talk about what happens when the robot fails. Can the robot fail? Yes, of course. So, in about 1 to 12% of the cases, as per the literature, the robot has had to be abandoned for various reasons. And these are the cases where the surgeon can panic, oh, what next? What do I do at this stage? The robot has stopped. So the best thing is to prevent the error ahead of the time. Most of the errors where the robot stopped, those were preventable errors. So ensure that you have got a good electricity connection, the UPS, the maintenance check of the robot is happening. Replace the worn out parts because you may want to use the same part again and again. And quality check all the instruments like pin, saw, and the handpiece. Remember that whenever you are using the robot for the first time or the early few times, you want to have your surgical profile because what you make in your profile is what it is going to give you the measurements. For example, if you are anterior referencer or posterior referencer, that can only be done only if you have put it on the surgical setting. You are CR surgeon or PS surgeon, what tibial slope you want, whether you want to look at the posterior condylar axis or the transepicondylar axis. So if you have not put in this data, and if you go with the auto data which is already there, it may not be as per your preference, and that's where the error can happen. So few errors which can be avoided, like checkpoint errors, because in the middle of the surgery, you may have that the checkpoint is not matching. And that is one of the errors which you can avoid by having a correct perpendicular checkpoint. Center of rotation error, where you might be struggling to get the complete circle. Sometimes it gets difficult. So it is very important that your pelvis is stable, the side support is loose, and you are able to take a good rotation without causing an error more than one. Sagittal axis error, yes, you do not want it absolutely perpendicular. You again are looking at how you're going to place your tibial tray, and most robotic systems would want your sagittal axis to be in this direction, where you're bisecting into 2/3 and 1/3 of the tibial tuberosity. Notching. So you do not want your robot to notch. I'm sure there are at least few surgeons who have had this problem where the robot probably did a little bit of notching on the anterior cortex. You may want to use your angel wing where the saw or the burr is going to cut, or best is you can use the same blade on the side of the femur and check it that whether it is going to notch or not. So this is like double or triple confirmation that you're not going to notch. There may be some machine related errors, and sometimes these small things might just pop up on the screen or on the handpiece where there is, the data is not matching what you're seeing in the clinical picture. There is a connection error, there is a play in the surgical plane, the surgical arm doesn't move at all, and there may be docking error with some of the robots. So there are some minor issues as well. Sometimes the arrays may not be in front of the camera. The acquisition can fail because of the pointer position. There may be incomplete acquisitions with the robot. So all these things have come with your individual experience, that in one case you face this problem, the other case you feel the other problem, and you might just say the company person, oh, this is not working fine. But the fact remains that we need to be more diligent in our registration, in the assembly of the instruments, and that's what will help avoid these small errors. So know your systems well. There has to be adequate understanding of the systems program. So if you look at the manual of any of the robots, they have given in absolute detail that where your retractors should be placed in every step of the surgery, where your assistant should be standing in every aspect of the surgery. And this will avoid any camera related errors or positioning error, right? So read through the manual before you go for your first one. Some of the machine auto-diagnose their error, and they might give you a pop-up that this is exactly the error, and the company person might be able to help you understand that error and correct that particular step. So sometimes if the saw is turning off and on and off continuously, it is mainly a connection problem. If it is unexpected or resection plane look inaccurate, then you can assess this with the pointer, whether your cut surface is even or not even. So what would you do? Suppose your robot has stopped working, there is panic. What do? Immediately you say, oh, give me the conventional instruments, I know how to do it, I'll do it manually. Yes, that's a reflex. And there's nothing wrong about it. Did we do the manual ones too badly? We didn't. So if you're switching over to a manual option, that's probably fine. But if it is an error which you can easily solve, probably you can look into it and do it. So one easy thing to do is take screenshots at every stage of your robotic surgery. So if you have the planning screen, if you have a flexion screen, the range of motion screen, probably you ask somebody to click pictures. If at any stage of time your robot has stopped functioning, you can refer to those on those pictures, because that will help your conventional surgery as well. So what about the timing? Suppose your robot fails before you have taken any cuts. That is, if before you have taken the landmarks or before you have taken the tibial cut, no problem. Just reboot the robot if it's starting again and register yourself again, and probably do the registration again of all the landmarks. So that is easy. But what if the robot fails after you have taken the cut? So for example, the tibial cut is taken and the robot fails. Now one thing you can do is, if you are specifically if you're a gap balancer, if you're not a gap balancer, then probably you have to address the femur manually. But if you're a gap balancer, you could use the same tibial findings, because you have the pictures, you can use the same tibial cuts and degrees and program it into the robot and then continue with the femur, which is possible with gap balancing. Now suppose if it happens after you have taken the proximal tibial cut and the distal femur cut, you can easily take the manual jig of the femur, give it the rotation that you want, that you had planned. So again, you have the picture from before. If it says 0 degree rotation, you can just give 0 degree rotation, but on the manual jig, and you can complete the surgery. So it is important that you store the data at every step of the surgery. Now, so suppose it fails after you have taken your trials, that's fine. I mean, after you have taken all the cuts, after the chamfer cuts, that's fine. The only thing you're not able to check is whether your balancing is proper or not, but you can check it then manually. So this graph is very useful. Here, if you're happy with, suppose you're happy with this balancing, assuming you're happy with this balancing, you know that your femur is in 3 degree of flexion, it is 3 degree of external rotation, and probably you would want to keep it this way. The sizing will be there. So all these things will already be there to make you a better manual surgeon in case you're not cutting it the robotic way. So we all know, all the speakers who spoke today, they all spoke that robot has made me a better conventional surgeon. And this is very, very important. So even if your robot fails, remember that you are a better conventional surgeon now than what you were pre-era of robotics. So while we are living in the era of human-robot interaction, breakdowns are going to happen. In each of our practice, we are going to face a time where your robot will stop working. Don't panic, troubleshoot. Thank you.